Okay, let's get into this. It's pretty startling to hear that AIDS, what we call AIDS now, was first called GRID.
Mm-hmm. Gay-related immune disorder.
Yeah, that name really hits you, doesn't it? Thinking about how it was first understood.
Absolutely. Tells you a lot about the fear and, frankly, the stigma right from the start. But the science, the journey since then has been incredible.
Exactly. And that's what we're diving into today. We know there's just so much information out there about HIV and AIDS. It can feel, well, overwhelming.
It really can.
So consider this your guided tour. We're going to break down the essentials, drawing on Raj Pandya's book, Beyond the Virus, The Science of HIV Transmission and Prevention.
And it's a great source because it handles the science, yes, but also the human side of things. It aims for real clarity.
Precisely. Our goal today, understand what HIV and AIDS actually are, how the virus works, how it spreads, how we stop it spreading, and maybe bust a few myths along the way.
So good.
So let's start right there. What is AIDS exactly?
Okay, so AIDS stands for Acquired Immunodeficiency Syndrome. The book breaks it down nicely.
Acquired, meaning you get it, you're not born with it.
Exactly. Not congenital. Then immunodeficiency, that's the weakening of your immune system, your body's defenses.
Right.
And syndrome just means it's a collection of symptoms, signs that point to a specific condition.
Okay, so AIDS is the condition, the result. What causes it? That's HIV then.
That's it. HIV, human immunodeficiency virus. It's the virus that leads to AIDS. And the book explains it's a retrovirus.
Retrovirus, I've heard that term. What does that actually mean in practice?
It's pretty fascinating, actually. It means the virus carries its genetic info as RNA, but to replicate in our cells, it has to convert that RNA back into DNA. It does reverse transcription.
Ah, okay. Like translating its instructions into a language our cells understand.
That's a great way to put it. It uses a special enzyme, reverse transcriptase, to do that translation. And HIV is also a lentivirus, lenti meaning slow, so it causes disease that develops slowly over time.
Got it. And the history here, discovering this, it wasn't straightforward, was it?
No, not at all. As we said, 1981, doctors in the U.S. Noticed these unusual illnesses, mainly in gay men, hence that name, GRID.
Which really focused things, maybe unfairly, on one group.
It certainly did, but science moved fast. By '83, Luc Montagnier's team in Paris found a virus they called LAV, lymphadenopathy-associated virus.
And then almost immediately after?
Yeah. 1984, Robert Gallo in the U.S. independently found it too, called it HTLV3, human T lymphotropic virus 3. So 2 discoveries, slightly different names, intense time.
You can imagine the pressure.
Definitely. And the story continues. The book notes the first case identified in India was 1986 in Chennai.
Right.
And that same year, 1986, thankfully, an international committee stepped in and said, okay, let's just call it HIV, human immunodeficiency virus. One name, less confusion.
That makes sense. But remembering that first name, GRID, is important, I think. Shows how far we've come, but also the stigma baked in early on. Okay, so we know what it is. What does this virus particle actually look like? Can we visualize it?
Yeah, the book gives a good description. Think of a sphere, like a tiny ball about 100 nanometers across, really small.
Okay.
And it has 4 main parts. First, an outer envelope made of lipids, fats. And sticking out of that are these crucial nod-like things, glycoproteins, GP120 on the surface, GV41 going to the membrane.
And little keys on the outside.
Exactly like keys. They're what lets the virus latch onto and get inside our cells.
Crucial part then. What's inside the envelope?
Inside that is the core, the capsid. It's made of protein and has 2 layers. An outer one called P17, or matrix protein, and an inner one, P24, the main capsid protein.
P24, that sounds familiar. Is that important for testing?
It is. P24 is antigenic, meaning our immune system can recognize it and react to it. So yeah, it's often called the P24 antigen, a marker for the virus itself.
Interesting. So our body can see that part. What's inside the P24 core?
That's where the virus's blueprints are, its genetic material.
Yeah.
2 single strands of RNA, ssRNA. And finally, the 4th part, essential enzymes tucked inside. We mentioned reverse transcriptase, or P64. There's also integrase, P32, and protease, P10.
Right, reverse transcriptase for that RNA to DNA trick. What about integrase and protease? Their names kind of give it away.
They do. Integrase helps integrate, or insert, the new viral DNA right into our own host cell DNA. It literally stitches it in.
Wow.
And protease acts like molecular scissors. It cuts up long viral proteins made by the host cell into smaller functional pieces needed to build new, mature virus particles.
So envelope with keys, protein core, the RNA instructions, and the enzyme tools to replicate. It's incredibly efficient in a scary way.
It's a very effective biological machine, yes.
Now, you mentioned earlier that there isn't just one HIV. There are different types.
That's right. Another common point of confusion. There are two main types, HIV-1 and HIV-2.
Okay. What's the difference?
HIV-1 is generally considered more virulent, more aggressive, causes disease faster, and it's more easily transmitted. This is a type that's dominant globally, including India, America, Europe. And even within HIV-1, there are groups M and OP. Group M is the big one, responsible for maybe 90% of all AIDS cases worldwide.
90%. Wow. So what about HIV-2?
HIV-2 is less virulent, harder to transmit. It's mainly found in West Africa. It also has its own groups, A through H.
Right.
So same family, but different behavior, different impact.
That variation is interesting. It makes you wonder, how did humans get this in the first place? Where did it come from? The book touches on origins, right?
Yes, it does. The leading scientific theory points to SIV, simian immunodeficiency virus. It's found in monkeys in Africa, like African green monkeys.
Simian, like monkeys, okay.
And SIV is genetically very similar to HIV. The idea is that SIV jumped from monkeys to humans, probably through contact with infected blood or fluids, maybe bites, scratches, hunting.
The zoonotic jump idea? That makes sense.
That's the most widely accepted explanation. The book does mention another theory, though it's much more controversial and not really supported by strong evidence.
What's that?
It involves the polio vaccines used in Africa in the 1950s. Some were prepared using monkey kidney cells. The theory suggests these cells might have been contaminated with SIV, potentially introducing it to people through the vaccine. But again, it's crucial to stress this is highly debated, lacks solid proof. The direct animal-to-human jump is the consensus view. It does make you think about how difficult tracing origins can be, though.
It really does. Okay, so regardless of exactly how it started, let's talk about how it spreads now, between people. Which fluids are the main culprits?
Right. The book is very clear. HIV is found in high concentrations in certain fluids from an infected person. We're talking blood, semen, preseminal fluid, vaginal secretions, and cerebrospinal fluid, the fluid around the brain and spine. These carry the highest risk.
Okay, high concentration fluids. What about others, like saliva or tears?
They can contain the virus, but usually in much, much lower amounts. The book mentions tears, saliva, breast milk, urine. Transmission through these is way less likely in these very specific circumstances, if at all, for some like saliva.
So concentration matters. And it also matters how that fluid gets into someone else's body.
Absolutely. The virus needs an entry point into the bloodstream or across certain membranes. Susceptible areas are the mucous membranes, lining of the mouth, rectum, vagina, the tip of the penis. Also, any open cuts, wounds, or sores.
Broken skin or those moist internal linings. Got it. So what are the main ways this transfer actually happens?
Okay, several key modes. The book states the most common is intimate sexual contact, vaginal, oral, or anal sex. That's the primary route globally.
Right.
Then there's direct contact with infected blood or blood products. Think blood transfusions, though screening has made this very rare in many places now.
Okay.
A major issue is sharing contaminated needles or syringes, especially for intravenous drug use. That's a very direct route for the virus.
Makes sense.
Also, sharing personal items that could have blood on them, razors, toothbrushes maybe, even things like acupuncture or tattooing if the equipment isn't properly sterilized.
And unfortunately, transmission from mother to child is also possible.
Yes. This can happen during pregnancy, across the placenta, during labor and delivery, that's called vertical transmission, and also through breastfeeding, as breast milk can contain the virus.
Okay.
Less common routes mentioned include organ transplants from an infected donor, possibly during dialysis if equipment isn't clean, or artificial insemination with infected semen.
That covers a lot of ground. It really emphasizes specific high-risk situations. But just as important is what doesn't spread HIV, right? There are so many myths still floating around.
Crucial point. The book is adamant. Mosquitoes do not transmit HIV.
Okay, let's be clear on that. Why not?
The virus literally gets destroyed in the mosquito's gut. Plus, mosquitoes don't bite one person and then immediately bite another. They digest first. And they inject saliva, not the blood they just drank. Biologically impossible for them to transmit HIV.
Good to know definitively. What other non-risks does the book highlight?
Things like kissing, even genital kissing, unless they're open sores maybe, hugging, sharing food, utensils, drinks, insect bites in general, using the same toilet seats, bathing together, pools, casual contact like sneezing, coughing, sweat. None of these transmit HIV.
It always comes back to those specific fluids and a direct route into the body.
Exactly. Not through everyday casual contact.
That clarity is so important. Okay, so the virus gets in. How does it actually attack the body? What's the mechanism inside our cells?
So HIV's main target, as the book explains, are cells with a specific receptor on their surface called CD4. Think of CD4 as a docking station the virus uses.
And which cells have these CD4 docks?
The primary targets are a type of white blood cell, the helper T lymphocytes, often just called CD4 cells. These are like the generals of our immune system. They coordinate the defense.
Okay, the immune system generals.
But HIV can also infect other cells with CD4 receptors, like macrophages in the lungs, microglial cells in the brain. It can affect B cells, other lymphoid cells too. But the helper T cells are hit hardest.
So it's not just one cell type, but the helper T cells are ground zero.
Pretty much. So the process. HIV gets into the body. First, it often enters macrophages. Inside, reverse transcriptase does its job. RNA becomes DNA.
Right.
This new viral DNA then gets integrated into the macrophage's own DNA using the integrase enzyme. The macrophage is now essentially hijacked. It becomes an HIV factory, churning out new virus particles.
Wow, the cell becomes a factory for the enemy.
Exactly. Then, these new viruses leave the macrophage and infect the main targets, the helper T lymphocytes.
Okay.
Inside the T cell, the virus replicates again, making loads more copies. These burst out, kill the T cell, and go on to infect more T cells. It's a relentless cycle.
And that cycle leads to fewer and fewer of these crucial helper T cells.
Precisely. The number of helper T cells just keeps dropping. This weakens what's called cell-mediated immunity, the part of the immune system that directly attacks infected cells.
Right.
When the helper T cell count falls below a critical level, the book says around 200 cells per cubic millimeter of blood, the immune system is severely damaged. That person is now considered to have AIDS. They're immunocompromised.
And that's when other infections become a problem.
Yes, that's when opportunistic infections take hold. These are infections caused by germs, bacteria, viruses, fungi, parasites that a healthy immune system would normally fight off easily. Things like Mycobacterium, which causes TB, certain pneumonias like pneumocystis pneumonia, fungal infections like candidiasis, parasites like toxoplasma. Because the immune defense is down, these microbes seize the opportunity.
So the body can't defend itself anymore?
Not effectively. And it's not just infections. The risk of certain cancers also goes way up, like Kaposi sarcoma, which is linked to another virus, HHV8, or lymphoma, cancer of the lymph nodes.
So it's often these opportunistic illnesses or cancers that are the ultimate cause of death in untreated AIDS, not HIV directly.
That's generally how it progresses, yes. The patient often suffers from fever, chronic diarrhea, severe weight loss. Without treatment controlling the virus, the body succumbs to these other diseases.
It's a grim picture without intervention. Let's talk about the clinical signs then. How does this progression look from the outside? What are the stages?
Okay, the book outlines it clearly. First is the incubation period, the time between getting infected and symptoms appearing. This can be long, maybe 5 to 10 years on average.
Wow, years.
During this time, the person is HIV positive, the virus is there, but they don't have AIDS yet. AIDS is the late stage.
And within that long period, there's an asymptomatic stage.
Yes, the asymptomatic carrier stage. This is tricky because the person feels fine, looks fine, often doesn't know they're infected. It starts maybe 2-3 weeks after infection.
Do people never have symptoms early on?
A small number, maybe 3-5%, might get brief flu-like symptoms right at the beginning. Fever, chills, aches, maybe swollen glands, a rash. But these usually go away quickly. Then comes a long asymptomatic phase, could be 5, maybe 9 years.
But they are infectious during this time.
Highly infectious.
Yeah.
Even though they feel healthy. That's why it's sometimes called the blind phase. You can't tell by looking. Makes testing so important.
Absolutely. So what happens when symptoms do start to appear after that phase?
That's the early symptomatic stage, sometimes called RRC AIDS-related complex. The immune system is starting to noticeably weaken. The book lists major and minor signs.
Okay, major signs first.
Major signs are significant weight loss, more than 10% of body weight, sometimes called slim disease or wasting, and persistent fever lasting over a month without another obvious cause.
And the minor signs?
Things like swollen lymph nodes, lymphadenopathy bigger than a centimeter in multiple places like neck, armpits, groin, lasting over 3 months. A persistent cough for over a month, often due to lung infections starting up, like TB or that pneumocystis pneumonia.
Okay.
Also, mouth infections like thrush, candidiasis, that white coating, skin problems like shingles, herpes zosters, and drenching night sweats. These are all flags that the immune system is struggling.
It's a collection of signs that things are going wrong, and then comes the final stage.
Full-blown AIDS. This is formally defined by that helper T cell count dropping below 200, or by the appearance of those severe opportunistic infections or cancers we talked about.
Right.
So serious infections with mycobacterium, various viruses, fungi, parasites, Kaposi sarcoma, lymphoma, and sometimes AIDS dementia, complex cognitive problems like memory loss, confusion, depression, as HIV can damage brain cells too. This stage, without treatment, ultimately leads to death.
It's a devastating progression, but the book mentions some people don't follow this path. Non-progressors.
Yes, a really interesting group. These are HIV-positive individuals whose disease progresses very, very slowly, or sometimes seemingly not at all.
Why?
It seems to be down to their genetics, mostly. Differences in their immune systems that somehow manage to keep the virus in check much better, preventing severe damage. Studying them is super important, might hold clues for future therapies.
That offers a glimmer of hope, understanding that natural resistance.
Okay, so given these stages, how do doctors actually diagnose HIV? What are the tests?
The main screening test, as the book explains, is ELISA enzyme-linked immunosorbent assay. It looks for antibodies your body makes against HIV.
Antibodies, not the virus itself.
Correct. And that's key because there's a window period. It takes time for your body to make enough antibodies to be detected, usually 3 to 6 months after infection.
So a negative test soon after exposure might not be accurate.
Exactly. It could mean no infection, or it could mean you're in the window period. Need to test again later, typically after 3 months to be sure.
What if the ELISA is positive? Is that a definite diagnosis?
Not necessarily. ELISA is a screening test, very sensitive, but it can sometimes give a false positive. The book mentions other conditions like TB, malaria, even pregnancy or flu shots can sometimes trigger a false positive.
So a positive ELISA needs confirmation. Always. That's where the Western blot test comes in. It's more specific, looks for antibodies against individual HIV proteins. It's the gold standard confirmatory test.
Does it also have a window period?
Yes. Same 3 to 6 month window period applies. And it's more complex and expensive than ELISA.
Are there tests that can detect infection during the window period?
Yes, PCR polymerase chain reaction. This test looks directly for the virus's genetic material, its RNA.
Ah, okay. Detects the virus itself.
Right, so it can detect infection much earlier, often within weeks of exposure, well before antibodies are measurable. No significant window period.
Yeah.
Great for early diagnosis or testing babies born to HIV-positive mothers.
So ELISA to screen, Western blot to confirm, PCR for early detection. Got it. Now, treatment. You said there's no cure, but there are effective treatments.
Correct. No cure yet, unfortunately. AIDS is still considered fatal if untreated. But the drugs we have now are incredibly effective at managing the virus. They don't destroy it completely, but they stop it from multiplying. They're virustatic.
They keep the virus suppressed. How do they work?
They target those crucial enzymes the virus needs. One big class is reverse transcriptase inhibitors. They block that enzyme, stop the RNA to DNA conversion. AZT, or zidovudine, was one of the first and is still used.
Block step 1. What else?
Protease inhibitors. They block the protease enzyme, those molecular scissors, stops the virus from assembling new particles correctly. Foscarnet and Demerara are examples mentioned.
Okay.
Then there are integrase inhibitors. They block the integrase enzyme, stop the viral DNA from getting stitched into our DNA. Raltegravir is one.
So blocking multiple steps in the virus's life cycle.
Exactly. And that's the basis of HAART, highly active antiretroviral therapy. It uses a combination of drugs, usually from different classes, hitting the virus from multiple angles.
Is HAART the standard now?
It's been incredibly effective. Dramatically reduces the amount of virus in the blood, the viral load, allows the immune system to recover. The book also mentions nevirapine, specifically for preventing mother-to-child transmission, and some drugs, like ribavirin, that might help boost the body's natural antiviral interferons.
It's amazing how targeted these therapies have become. But since there's no cure, prevention is still key, isn't it? Which brings us to awareness programs.
Absolutely vital. The book mentions India's National AIDS Control Program, started back in 1987 through NACO. And globally, the WHO runs many programs.
And December 1st, World AIDS Day.
Yes, a crucial focal point each year. The underlying message always comes back to prevention is better than cure. Because, well, we don't have a cure. Education, testing, safe practices, they're paramount.
Definitely. Okay, let's just quickly recap the absolute key takeaways for everyone listening.
Sure. So HIV, it's a retrovirus, uses reverse transcriptase.
Check.
main target. CD4 helper T cells, weakening the immune system.
Got it.
Transmission. Primarily sexual contact, infected blood, mother to child. Know the risks.
Crucial.
Diagnosis. ELISA screens, Western blot confirms. PCR detects early.
Okay.
Treatment. Antiretroviral drugs like RT inhibitors, protease inhibitors, integrase inhibitors, often in combination, heart, suppress the virus. No cure, but effective management. And AIDS itself is characterized by that low CD4 count and opportunistic infections due to the damaged immune system.
It's a great summary. Pulls it all together.
You know, when you lay it out like that, the progress in understanding and treating this from grid to heart, it's just phenomenal, really.
It truly is. And we really hope this deep dive, drawing on beyond the virus, has given you a clearer picture, maybe helped cut through some noise and outdated fear.
Which leads to maybe a final thought. The book touches on social dimensions, too. So here's something to ponder.
Okay.
With all these medical advances in treatment and prevention, how do you think that's actually changed the stigma around HIV? Has it lessened? Stayed the same? And what more needs to happen culturally, societally, to really overcome that stigma that still causes so much harm?
That's a really powerful question, something for all of us to think about long after this discussion ends. We definitely encourage everyone to keep learning, keep seeking good information. Hopefully, this deep dive gave you a solid foundation.